Hello, everybody. This is Dan Bruns. Good to be talking to you today. I'll be talking, of course, about presurgical psych evals for spinal cord stimulation. I have a couple of disclosures. I'm a co-author of a psychological test along with Mark DeSorbio. In the past, I've worked as a consultant for SCS device manufacturers. So those are my disclosures. An overview. We'll be talking about what is spinal cord stimulation and guidelines, psychological test selection for SCS, how to conduct the evaluation, and using the medical intervention risk report for these evaluations. I want to start with a quote from 2,400 years ago from Hippocrates. He said, "It's more important to know what sort of person has a disease than to know what sort of disease a person has." I think that was really prophetic words, and this is why we do surgical psych evals. We need to know our patient better. Let's talk about some basic SCS concepts. So what is spinal cord stimulation? It's an electrical treatment for pain, an alternative to opioids. SCS is most commonly used for non-spinal pain, such as pain in the arms, legs, gut. So pain that's some distance away from the axis of the spine. This schematic drawing shows what it looks like when installed or implanted. You see a pulse generator over there on the left and wires going up into the spine called leads. These deliver electrical impulses to the spine, and this in turn creates a signal that travels both up and down nerve fibers in the spine. SCS works by electrically interrupting pain signals and replacing them, in most cases, with a tingling sensation called a paresthesia. So think of how your hand or foot feels when it falls asleep. That's a paresthesia, and the feeling you get is something like that. Most people find that paresthesia less aversive than the pain experience that it replaces. These are two different pulse generators from different manufacturers. You can see they're about 2 inches square, maybe 3/8 of an inch thick. These are the leads. On the top there are two cylindrical, what are called percutaneous leads. Percutaneous means through the skin. They're implanted with a needle. And these are the easiest types of leads to install. They're installed next to the spinal cord. Also, what are called paddle leads. These are much larger, much more difficult to install. You have to remove part of the vertebra, the lamina. So typically, the person has to undergo a laminectomy to make space to put this lead in. Many think these leads provide better stimulation, but they're much more difficult to install, and as a result, almost all the time, it's percutaneous leads that are used. Now, there are so many different types of SCS and purposes. It's beyond what we can cover today. But if you go to this link, psych.com/scs.html, there are links to a number of review articles, a 50-page primer on electrical treatments, and other articles and videos. Maybe don't go there now. You might disconnect from the webinar. But I will show this link again at the end. Now, surprisingly, a multitude of payers, organizations, and guidelines require psychological evaluations prior to SCS. In fact, it's almost universal. So it's Medicare, Medicaid, private payers, pain societies, guidelines. Pretty much, they all now require a pre-surgical psych eval prior to SCS, which is kind of remarkable when you think about it. So how can a psychological evaluation predict SCS outcome? How does that work? In an article we published on SCS earlier this year, there's a quote, "SCS is a surgical treatment whose success is based on its ability to change the patient's verbal behavior." Now that's, I think, kind of an astounding thing when you think about it. If, for example, if before SCS treatment, the patient says, well, my pain is a 9, and after you turn the stimulator on, they say, well, my pain is a 4, their verbal behavior just changed. And something that's often overlooked is we're using this treatment to change verbal behavior, what a patient says. So the goal of SCS is to reduce reports of pain and produce patient satisfaction. How can we predict that? So what predicts surgical outcome? There have been multiple studies that have found that psychological tests can outperform medical tests at predicting poor response to back surgery. If you think about the outcomes, if we're basing the outcome to a considerable extent on what patients say, an X-ray doesn't predict who will be satisfied. An MRI doesn't predict future patient happiness, but psychological measures can. And so that's why they can outperform medical tests for predicting outcome. Let's talk about test selection for SCS. There are two basic categories of tests to think about which give you different information. There are psychiatric inventories, and there are pain or health psychology inventories. Let's think about how they differ. For a psychiatric test, the target is a psychiatric patient. For a health psychology test like the BHI-2, and I'm using that as an example here, the target is a medical patient. So the central construct for a psychiatric test is assessing DSM-type disorders. For a health psych test, it's a biopsychosocial disorder, which may have both psychological and medical components. Both kinds of measures assess depression. A psychiatric inventory may look at depression associated with mood swings, like you might see in mood disorders. The BHI-2, one of the scales is medical reactive depression. So it's asking the question, is your depression associated with a loss of health? Like, are you depressed because you broke your leg and can't run anymore? Both kinds of tests assess anxiety. Psychiatric tests may assess irrational phobias. BHI-2 has a measure called death fears. I treat patients with cancer pain, and for some of those, death is a possibility. And so it's not an irrational fear, it's something that's actually a possibility. Both tests can assess chemical dependency. Psychiatric tests may assess alcoholism, for example. Well, the BHI-2 looks at dependence on prescription medication. Those are distinctly different, obviously, because nobody prescribes beer to get better, but physicians do prescribe opioids. And so the context of the chemical dependency is entirely different. Now, you may wake up from surgery with a morphine drip, didn't even ask for it, but you're on morphine. So it occurs in a very different social context. Physical symptoms. Psychiatric tests look for physical symptoms that may suggest somatization. In the BHI-2, we're looking for how well your symptom pattern fits with your medical diagnosis. Both may assess social factors. Conflict with spouse versus conflict with your treating physician. So a lot of overlap, but distinct differences as well. So weaknesses. BHI-2 doesn't make any attempt to measure mood swings. That wasn't part of what it was designed to do. Now, personality inventory might do that, but no personality inventory includes pain ratings. No personality inventory would ask, so on a scale of 0 to 10, how much foot pain do you have? There's no reason for a personality inventory to ask that question. There's no psychiatric diagnosis for which foot pain is a sign. But there are medical reasons to ask it. Gout, sciatica, diabetes, arthritis, all of these things could potentially cause foot pain. So with a biopsychosocial assessment, that's something you might want to know. So while the BHI doesn't assess mood disorders, it's designed for pain disorders and it has 27 measures pertaining to pain disorders. First of all, it asks about pain in 10 different body areas. head pain, foot pain, back pain, stomach pain. It asks about pain variability. Is it the same all the time, or does it go up and down? How much pain can you tolerate? What are your beliefs or cognitions about pain? Is the pain widespread, or is it more focused? Does the pain fit anatomically, or is there a non-anatomic distribution? Are there signs of central sensitization for pain? Are you afraid of painful exercise? Do you believe that the pain is disabling you? These are all relevant questions for pain disorders, and one of the BHI's strengths is assessing pain disorders. One of the things to think about when assessing medical patients is something that we've called the psychological fallacy, which is that on most DSM-type psychiatric measures, any physical symptoms that are present are there because they're thought to be signs of psychiatric syndromes. So if you pick out a psychological scale or inventory and you scroll through the items and there's a physical symptom, it's only there because it's scored as a sign of some psychiatric syndrome. But the fallacy is we can't always interpret physical symptoms as being psychiatric in origin. Let's think of an example. Suppose the patient says, I've been sleeping 12 hours or more a day, I have no libido, I've been gaining weight, and I'm tired all the time. You might say, oh, well, that's probably depression. But all of those symptoms are also side effects of amitriptyline, a medication that's commonly prescribed for pain. So these all could be medication side effects. And if you assume these are all psychiatric signs, you can get a false positive score. And if we would change weight gain to weight loss, well, those could all be consistent with chemotherapy. There's an old but still interesting study about the effects of chronic illness. And if you take patients who have a chronic illness and administer a psychiatric inventory, about 1/3 of the variance of their responses is due to disease severity. And so the more severe the disease, the more likely they are to look like they have a psychiatric condition, when that may or may not be the case. On the BHI-2, we took a number of different steps to try to reduce the risk of false positive findings. One was in the BHI-2, we have 2 depression scales. One depression scale called vegetative depression has all of the biological type symptoms, where the standard depression scale has thoughts and feelings associated with depression. So those are less affected by biological factors. So this way you can separate out the 2 different aspects of depression in patients who are chronically ill. Another example, the patient reports difficulty swallowing. That's a classic sign of somatization. If you have orthopedic patients, that's a classic complication from cervical fusion. And if you work with cancer pain, that's a classic sign of a laryngeal cancer. And so if you have a patient who's chewed tobacco for 20 years and reports difficulty swallowing, you shouldn't assume it's somatization. On the BHI-2, we have multiple techniques we use to try to reduce the risk of false positives. Here's a little screenshot showing how it interprets difficulty swallowing, that it could be somatization, or it could be the other things too. We'll talk about other things the BHI-2 does as well to try to sort out the differences between medical patients and psychological patients. As a rule of thumb, when you're selecting tests for an evaluation, what are you trying to assess? Different tests have different strengths and different weaknesses. And so you should think about what risk factors are important under the circumstances to assess and select your tests accordingly. Let's talk about conducting the presurgical psych eval for SCS. We did a study in 2009. It was a review study on what are the risk factors for spinal surgery and spinal cord stimulation. Now, this study had been adopted by 3 different guidelines. And so we'll be talking about this more in a bit, but basically it breaks it down into a two-tier assessment process: primary risk factors, or red flags, and secondary risk factors, or yellow flags. So we defined primary risk factors as dangerousness to self or others, psychosis, active substance abuse, or signs of severe psychological instability. We actually define that psychometrically as above the 99th percentile. When you see a red flag, you should stop and reassess before proceeding to any elective surgery. Our group has probably published more studies on primary risk factors. Now, these are important, but there's been almost no research on them. And so we went to some effort to get extreme patients. And we found 80 patients with a plan for suicide, 49 with homicidal ideation, 62 with suicide-homicide ideation, 71 patients with thoughts of killing their physician, and 60 patients with thoughts of suing their physician, and 7 other studies as well. And we used, in each case, the BHI-2 to predict those risk factors. And these are all, again, patients with chronic pain. And so we've gone to considerable lengths trying to see if we can actually predict these high-risk patients. And in each case, we could. Let's think about how this plays out in the clinical setting with a conversation between doctor and patient. And here a physician says, "How are things going today?" And the patient says, "I'm so furious I want to sue somebody." So the physician correctly states, "Let's stop and reassess. Why are you so angry?" Sometimes patients have extreme feelings. It can be extreme anger, extreme depression, extreme fear. When they reach a certain point, it becomes a primary risk factor. And we need to stop and just reassess what's going on and intervene because the patient is so emotionally distressed, it's very likely to interfere with a person's response to any medical treatment. So while primary risk factors are important, they are less common. Yellow flag risk factors are the common cold of risk factors. Almost every patient has some, and these are like moderate levels of depression, anxiety, poor pain coping, poor physical functioning, somatization, job dissatisfaction, and so on. These are much more common. And almost all research about surgical outcome is about yellow flags due to the difficulty of doing studies on the extreme red flags. It's really hard to do a surgical outcome study on people who are imminently suicidal. Now, almost all medical patients have some secondary risk factors, so it's the number of risk factors that are present that is important. There have been 2 systematic reviews about secondary risk factors by Denboer and Celestin. We also did a study ourselves in 2009, and this review looked at both the empirical factors like Denboer and Celestin did, but also the consensus risk factors because, unfortunately, there are a lot of things that haven't been researched. So we defined these primary and secondary risk factors psychometrically, and then tested them using 1,200 patients to see if these risk factors predicted objective outcome, like was the patient employed or not, and subjective outcome, was the patient satisfied with care or not. And in almost all cases, they predicted significantly. And that's one of the articles you can download from the link I provided earlier. Another study found that the presence of 4 or more secondary risk factors increases the risk of a presence of a psychological disorder by a factor of 14 and doubles the risk of failure to return to work. Note that studies have also shown that these high-risk patients can be treated successfully with interdisciplinary care. So, again, a conversation between doctor and patient around secondary risk factors. How might that go? Like, so, you've been having a lot of back pain. The patient says, actually I have pain in every part of my body. I'm afraid that PT will injure me further, so I'm not going. And I can't work unless my pain level is 0. And my attorney wants you to testify that I'm disabled for life. And can you please increase my oxycodone dose? I really like it. So there's no primary risk factors there, but the prognosis is not looking good for a patient who reports all these secondary risk factors. So let's think about predictive models. How do you predict heart disease? So if a patient has high blood pressure and is obese and uses tobacco and has high cholesterol and has untreated diabetes and doesn't exercise and has a family history of heart disease, and there might be other risk factors like do they use aspirin or not, and a variety of other risk factors as well. So you take those variables, you could put those into a regression equation and come up with a prediction of heart disease. There's a lot of health sites that do that. You can load in these variables and they can say, well, here's your risk of a heart attack. You can do the same thing with predicting spinal cord stimulation. So if we think about the predictive models for SCS outcome, is the patient depressed or anxious? How's their stress level? What are their beliefs about pain and exercise? Is it widespread or localized pain? Do they crave pain medication? Do they see themselves as disabled? Is there secondary gain for their pain? And there's actually as many as 50 other variables that you could consider. So we could use those to develop a predictive equation for SCS outcome. Or we could do the same thing for spinal surgery generally, or a response to physical therapy, or poor coping, or opioid abuse, or minimizing or magnifying, or suicide risk, legal risk, or violence risk. So if we develop all those predictive equations, what we would have is the medical intervention risk report. That is essentially what we did. We were trying to find predictive equations for all of these different conditions. And here's the profile that you see. So let's talk about the BHI-2, Battery for Health Improvement. The inventory, it's a comprehensive biopsychosocial assessment. 217 items, takes about 35 minutes to take. It was designed from its inception to assess chronic pain secondary to illness or injury, and also somatoform disorders generally. BHI-2 has 10 different norm groups based on about 1,400 different subjects from 106 sites. There's the basic norm group is patients in treatment for pain or injury, and also a healthy person group as another context to interpret the results by. There are also 10 pain subgroup norms: chronic pain as opposed to acute pain, headache pain, neck pain, arm pain, back pain, leg pain, fake health and pain good, fake health and pain bad. So the original BHI-2 has 18 scales, 40 subscales, and the 27 pain-related measures we noted earlier. Now the BHI-2 meter has 6 additional scales related to treatment risk. This is more understandable to physicians. It's also, you can think of it like a second test that uses the same items. So giving the same set of items, you can score one or both of these measures to get the information that you're looking for. So let's look at the BHI-2 original report. Here's the 18 scales, and there are validity scales on top. There are biological scales, physical symptoms, pain complaints, functional complaints or disability symptoms, muscular bracing, which is about a psychophysiological response to stress, There are psychological scales: depression, anxiety, anger, borderline symptoms, dependency symptoms, maladjustment, substance abuse, perseverance. Perseverance is like a positive psychology scale looking at optimism and self-efficacy, and social scales, conflicts with job, physician, family, and survivor of violence. It's kind of like an ACE scale, adverse childhood experiences, except it's childhood and adult, so it's more like adverse lifetime experiences. So all of those together are assess the biopsychosocial paradigm. So BHI-2 report components, this is the original test. You have, besides the main scales, you have 40 subscales assessing various things. Pain complaints item responses, where it compares a patient's pain reports to a national sample of other patients in the same diagnostic category. We'll come back to this in a bit. It has a narrative which explains what the scales mean. It has treatment recommendations and also a patient summary. Now, this is a part of the report that is prepared for the patient, and so it interprets the BHI-2 in more patient-friendly ways. For example, it doesn't say that you are defensive if the scale is if they have a high defensiveness score. Rather, it says the test results suggest that you're a private person and you have some concerns about who gets this information. So it tries to interpret the test results in more patient-friendly ways. And you may also look at that to think about how best to talk to the patient in a way that's not threatening. So the other tests scored from these items, the medical intervention risk report. The BHI-2 MIR identifies risk factors thought to negatively impact a patient's response to medical treatments, and also makes suggestions for behavioral alternatives and how to reduce these risk factors. Here are the scales. There's self-disclosure, which is a validity scale. Do they exaggerate or minimize the information they present? Primary risk factors: danger to self or others, severe psychopathology. Are there extreme risks present? Presurgical risk: what are the risks for poor outcome from surgery? Rehab risk: this is similar to presurgical risk, but it includes a broader set of predictors, and it's trying to predict a broader range of medical treatments, including things like treatment in physical therapy, treatment in an interdisciplinary setting, treatment for brain injury. So it looks at a broader range of treatments. Addiction history is more a classically antisocial pattern. A person who has abused alcohol, abused drugs, maybe failed drug treatment, has been in jail, and so brings all this addictive history into the medical setting and is at a higher risk for abusing opioids. In contrast, we have what we call the addiction potential scale. This is a patient who doesn't have any antisocial tendencies, but rather is a distressed patient who copes with pain poorly, may have a very painful injury, copes with it poorly, and loves the medication too much, and is at risk for it getting out of control. Catastrophizing is exaggerating the negative aspects of life. Kinesiophobia is a fear of movement. It's a fear that exercise or activity will cause injury, and so these patients don't do well in physical therapy because they're exercise avoidant. We can look through the medical intervention risk report. There's a cover page. The chart talks about validity and primary risk factors, presurgical and rehab risks, addiction risks, what are called non-adaptive coping styles, the catastrophizing, kinesiophobia. It offers recommendations for risk reduction in high-risk patients. How do you help the patient who's at high risk? It suggests specific psychological treatments and also lists patient strengths. So that's what the MIR report offers. let's talk about some case studies. So a 59-year-old male, loves the outdoors, hiking, had a lumbar injury while skiing, has chronic sciatic pain radiating into his leg. Will spinal cord stimulation help? So if we see the MIR report, first of all, the MIR report, we can see on the left side we have the scales. And in the middle, we have this gray zone, which is the average range. And you can think about this as being like a CBC, where it can be really high or really low. These are all standardized T-scores, mean of 50, standard deviation of 10. We also provide a percentile rank. Physicians understand percentiles much better than T-scores, so we offer that as well. And an overall risk rating. So you can see with this patient, all the scores in the average range are actually trending low. So this would be a good patient for SCS. No recommended actions. You could offer pain management training, perhaps. What's most evident are patient strengths. Here's a second case, phantom pain. You have a 44-year-old male, traumatic amputation of hand in work-related accident. And the problem is phantom pain. The patient felt like his missing fingers were being bent backward to the breaking point. Now, sometimes in phantom pain, people have all kinds of sensations caused by the traumatic injury to their nerves. And so this patient is also taking high doses of opioids. So, good candidate for SCS. So here we have the medical intervention risk report. The surgical scales are in the high average range, so they're not elevated, but they're a little bit above average. And this patient is taking a lot of opioids, but not an addict profile. So there's no history of addiction or incarceration, failed drug treatment. But addiction potential is high at the 91st percentile. That's compared to other patients in rehabilitation, 91st percentile. So this patient likes opioids a lot. Catastrophizing. This patient is also prone to catastrophizing. That's also high at the 91st percentile. So, what does that mean? The presurgical scales weren't elevated, and so while the patient has some risk factors, the high average range, they're still in the average range. And what you'd predict is the patient would likely say, yeah, the SCS helped, but likes opioids a lot and is likely to say that, yeah, SCS helped, but I still want the opioids. And so SCS isn't likely to get them off the opioids. That's a separate question. And also catastrophizes and is likely to still have suboptimal coping. So while the patient isn't a bad candidate for SCS, the risk factors are in the high average range, and ideally, a person could have SCS plus psych treatment for catastrophizing and for opioid dependence, and that would be a better treatment plan than just SCS alone. Let's take a complicated case, gunshot wound. 37-year-old female, gunshot wound to the right upper arm in a drive-by shooting targeting somebody else. So she was in the wrong place at the wrong time, lived in a high-crime neighborhood with gang activity. Now, remarkably, the second time she had been shot. Some years previously, she had been shot by another kind of random event, had a .22 caliber bullet go through her thigh, didn't really cause any major complications, This one was more serious. It was a 9 mm wound to her upper arm. And this did a considerable amount of tissue damage. And so she developed CRPS, chronic regional pain syndrome. This is a condition caused by nerve injury, which can cause out-of-control inflammation and intense pain. And so this is one of the primary indications for spinal cord stimulation treatment. So this is a more unusual patient. How did her profile on the MIR look? Okay, well here we have a very elevated profile. First of all, we see a bunch of yellow flags and a red flag. So we have 5 elevated yellow flag scores. The pre-surgical risk, we have a risk, addiction history, addiction potential, catastrophizing kinesiophobia. These are all yellow flag criteria, secondary risk factors. And what we saw previously is that we can come up with regression equations to predict different things. And so these are those equations, or those scales. And then we also have the primary risk score, which is very high. So what do you do with a patient like this? Now the primary risk factors are based on extreme scores, and these are scores, again, above the 99th percentile compared to other patients in rehabilitation. So, the average patient in rehab may be distressed. That's not a happy time in their life. But this is above 99% of patients in treatment. So she had extreme depression, extreme anxiety. That included extreme measures of panic, generalized worries, death fears, all highly elevated. She had extreme problems with functioning and signs of extreme stress as well. So 4 primary risk factors were present. Now, we can also review the original BHI-2 results here, and this is what we would see. Now, she has a positive finding, in the sense of good, job dissatisfaction. Very, very low. That means she loves her job. So a source of stability in her life. So it's good to know that there's a positive finding here. Perseverance, however, very low. This is a patient who says, I can't do this anymore. I quit. And extreme anxiety, extreme depression, signs of extreme physical distress. So an extremely distressed patient. If we look at the subscales, there's a lot going on in this profile, and it would take a while to go through all the scales, but I want to point out just a few things. One is death fears very high. She'd been shot. She lived in a high crime neighborhood. She was literally scared to death about what would happen to her. Autonomic anxiety, these are the physical symptoms of anxiety. Pounding heart, shortness of breath. She was having panic attacks. So again, highly, highly distressed patient. These are her pain complaint item responses. And so here you see on the left her pain reports. And on the right here in blue, this is based on a national sample of 220 patients with arm injuries to see how do her complaints compare to medical patients with just an arm injury. And you can see they're substantially different. Much more headache pain, much more facial pain. So these are substantially different than just an arm injury. So are her reports anatomic or not? And looking at this, it's kind of hard. It looks different, but there's actually a mathematical way of trying to see how well things fit. So if we use mathematical modeling, we can come up with diagnostic probabilities. So what's the percent match between a patient's distribution of pain symptoms and different diagnostic categories? Now, and this used 10 discriminant functions to do this, so the math is a little bit complicated here in terms of the modeling. But selected by clinician, I put in, she had an upper extremity injury, she was shot in the arm. But predicted by the BHI2, headache. Now this can be like TBI headaches or migraine headaches. It turns out that they weren't significantly different, and so they're grouped together. But if the BHI2 said this is more of a headache pattern, so there's an 83% match with upper extremity injury, but 96% with headaches. So it's like, we've all been focused on her arm, but she has a major headache problem too. And in fact, that seems to account for more of her pain symptoms than her CRPS, surprisingly. And if we look back here at this one score, muscular bracing, 99th percentile, so a lot of her anxiety was being converted psychophysiologically into tension, and that may have been contributing to pain elsewhere in her body, like chronic tension headaches. So, how much of this is CRPS? So she definitely does have CRPS, but also has chronic headache pain associated with extreme anxiety, extreme stress, and muscular bracing. How do we help this woman? Well, she's a really high risk, and if we're patient-centered, what is the best thing we can do for her? Obviously, SCS won't make her safe, and so the first thing I thought about, this is a safety issue. Now, while she had been in treatment, she had begun living with her boyfriend, and I asked, well, how is that going for you? You're in a safer situation now. Is that work for you, or what about living with your family or moving someplace else? And we started processing, you are so stressed out now. Your stress is past the red line. Can we get that under control first before we start adding the stress of a surgery? And so we're processing her thinking about how to stabilize her life and not add stress with a surgery now, but first make her safe. And what we talked about is, a lot of your pain symptoms now are due to your stress level. Once we treat your stress, your pain symptoms may look different and may alter what we would do. So what if we just try to manage your stress now, and then later on, let's think about reassessing you for this treatment. And she thought that was a good idea. Fourth case history. 58-year-old female, professional with a master's degree. Had a staph infection following a total knee replacement and chronic leg pain. Has been talking to an attorney about her health care, but has not retained one yet. She had developed a staph infection after a total knee replacement. She had called in to complain that thought something was wrong, and they said, no, everybody has pain after knee replacement, don't be a whiner, and come back in a couple of weeks. And so they didn't find the staph infection until it progressed pretty far down the road, and she was angry about that. So, candidate for spinal cord stimulation. So on the MIR report, primary risk factors, there were two. Wasn't elevated on presurgical risk, but was in primary risk. So sometimes to get more information, you can also run the original BHI2 report. It gives you some additional information. Here's what we found. Here's something positive: chronic maladjustment, low. She had a master's degree, excelled in her professional life. That she did well. In her personal life, not so much. Had borderline personality features, prone to volatile interpersonal relationships, could get into love-hate relationships, be self-destructive at times. And doctor dissatisfaction, extremely high, 99th percentile. Now, doctor dissatisfaction is different. There's a lot of medical satisfaction scores. This is about the negative side. What we found is that if you love your doctor is okay, it's not really a problem. But if you hate your doctor, if you think your doctor has gone over to the dark side of the force, if he's an agent of the system, an uncaring person, then that's the doctor dissatisfaction scale. And if you have an intense belief that physicians are unempathic and incompetent and don't really care about you, that's really a problem. And that's where she was. She had intense conflicts with physicians and was planning to sue for malpractice. So what do you do? Now, she was high. These are some of the BHI subscales. High on compensation focus, said they owe me money for my pain and suffering. Also, very high in suicidal ideation. Now, there's a quote here from the MIR report, which says, this patient reports severe conflicts with the medical profession, including reports of dissatisfaction with medical care, a history of emotional instability, and feeling entitled to financial compensation. This patient's profile is also associated with thoughts of nonviolent retribution directed towards physicians. So, what our research on litigious patients found was that some of these patients will want to sue. More commonly, they might file a board complaint or may trash you online, which has become pretty easy these days. And also, this is just a really angry, distressed, and suicidal patient. So what can you do? Now, this patient may or may not have a valid complaint against their physicians. We know she's extremely angry, suicidal, and so primary risk factors. One is suicidal. The other is extreme conflict with physicians. First, you manage suicide risk. Just make sure she's safe. Secondly, given her extreme conflict with and distrust of physicians, I'm not sure this is the best time to do surgery. We need to try to help her develop rapport with her current physician. We don't want to repeat that pattern of her being unhappy with the physician. So she needs to have some time with building rapport with a new physician, and also explore alternative low-risk treatments if possible. So, some physicians with SCS Evals want only a yes or no. Are they cleared for surgery or not? And they don't want to know. They just want to know, is this patient crazy? And there's pressure to clear everybody. But the way I approach it is with each patient, what is the best thing to do for this patient? Maybe it's spinal cord stimulation. Maybe it's not. And part of these risk factors is it's not trying to deprive a patient of care. They're rather trying to predict, will you be happy you did this? Will you function better afterwards? And what I tell patients is, I'm not here to prevent you from getting something you need. I'm trying to help you figure out what is the best thing for you. So that's my approach. What is the best thing to do for patients? That's my guiding rule. And if a patient is at high risk, okay, well maybe now isn't the time, but maybe we can reduce those risks first and then do the surgery or procedure when the risk level is lower. So that concludes my information here. Now again, here's the link, healthpsych.com/scs.html for more information about a variety of things, including some of the articles I cited.